Good morning, everyone, and I'd like to thank the organizers for inviting me to make this presentation. I'd much rather to have done it from Verona than from New York, but sorry I can't be there. So what I want to talk to you quickly is the latest presentation that we made at the AATS regarding the CALGB 140503 trial. These are my disclosures. Just a rapid reminder about our previous report in the New England Journal, where we reported on 697 patients that were randomized to either lobectomy, 357, or sublobar resection. And this is just a table that shows that the baseline demographic and clinical characteristics were similar between the two groups. And we had three stratification factors, as you recall: tumor size, which had three categories of stratification; smoking status, which had three categories, including never smokers. I'll just draw your attention to the fact that in contrast to the JCOG 0802 trial, never smokers here constituted less than 10% of all patients. And the other stratification factor was histology. Again, the difference from our Japanese colleagues is that adenocarcinoma constituted a little over 60% of the patients compared to over 90% over there. The primary endpoint of the trial was non-inferiority of sublobar resection relative to lobar resection for disease-free survival. And after a median follow-up of 7 years, disease-free survival was 64% after lobectomy and 63.6% after sublobar resection, and the p-value for non-inferiority was 0.02, and the hazard ratio was 1.1. Now, sublobar resection, I would remind you, included both wedge and segments, so we left it to the discretion of the surgeon. A secondary endpoint was overall survival. As you can see, there also is no difference in overall survival between the two arms of the trial. It was about 79% after lobectomy and about 80% after sublobar resection. The hazard ratio here is 0.95, so it's moving slightly in the opposite direction, suggesting that overall survival may be a tad better after sublobar resection. The Japanese trial definitely showed superiority of segmentectomy to lobectomy for their primary endpoint of overall survival. We did an exploratory subgroup analysis looking at all the variables that may have impacted disease-free survival. As you can see, the midline here is 1, and all the black boxes are right on the midline. Specifically, there was no difference in age over 70 or less than 70, no difference by histological type, by smoking status, or by tumor size, and no difference based on tumor location in DFS between the two arms of the trial. We also looked at the time in the New England Journal paper at the cumulative incidence of death from lung cancer or from competing causes of death. The solid lines are the lung cancer-related deaths. The green is the sublobar, the red is the lobar. And, you know, at the beginning, there's more death from the sublobar, and then there's more death from the lobectomy. These differences are not statistically significant. And the dashed lines are the competing causes of death. And as you can see, they're superimposable, so no difference in either type of death between the two arms of the trial. Surprising thing that we found is that recurrence overall occurred in 30% of the patients, similar between sublobar and lobar resection. Isolated local regional recurrences, which is something that surgeons care about, was 10% after lobectomy, 13% after sublobar resection, and 11% overall. About of the 30% who had a recurrence, about half of these recurrences were systemic, suggesting that this is a category of patients that we should consider additional therapy for. And you know, you may attribute that to the sublobar resection, but look here at the lobectomy group, and these patients had the smallest lesions, had the best operation, and still more than 50% of their recurrences were systemic. So the big question was the issue of the sublobar resection, segmentectomy versus wedge. This is the design of the trial. The original analysis was based on the intention to treat, in May of this year, we made a presentation at the AATS meeting in Los Angeles to try and look closer at the impact of this extent of parenchymal resection on outcome. And here our analysis was based on the intention actually delivered, not the intention to treat. So as you can see from this slide, there were 5 conversions from lobectomy to segmentectomy and 10 conversions from segmentectomy and wedge to lobectomy, which yielded 362 lobes, 131 segments, 204 wedge resections, the same stratification factors. The objective was to look at differences in survival endpoints based on the extent of resection, lobe, segment, or wedge, and also to more specifically focus on the differences between wedge and segment with regard to margin and recurrence and pulmonary functions. So these are the 3 groups. Like I said, there is no difference in the baseline characteristics with respect to age and gender or performance status. What's important is that the median tumor size was exactly the same across all 3 groups, and there was no difference in the stratification factors of tumor size as well as smoking status. As you can see, still never smokers represented less than 10% of the patients in all of the 3 groups. The third stratification factor was also similar. Again, adenocarcinoma constituted a little over 60%, maybe a little higher in the segmentectomy group. And what about nodal staging? So a lot of the concern was about the adequacy of nodal staging. You can see if you just look at all the 99.9% of the patients had at least simple sampling. What do we mean by simple sampling? It is the minimum requirement for being randomized. 2 mediastinal nodal stations had to be sampled and 1 major hilar nodal station. So everybody got the minimum amount of nodal staging required by the trial. When we specifically looked at the wedge resection group, they were more likely to have this simple nodal sampling. So about 1/3 of them had simple nodal sampling, but paradoxically, wedge resection patients also had the most frequent use of complete mediastinal node dissection. Perhaps the surgeons were a little concerned about doing a wedge, so tried to make up by doing the complete mediastinal node dissection. At any rate, nodal upstaging, so node positive disease, was present in 6.6% of the lobectomy group and 5.8% of the sublobar resection group. These differences are not statistically significant. So disease-free survival is shown here with a median follow-up of 7 years. There is essentially no difference in 5-year disease-free survival between the 3 groups, wedge and segment, with 62.5% after wedges, 63.8% after segment, 64% after lobectomy. The p-value was 0.88. Overall survival was also exactly similar between the 2 groups. Lobectomy 78%, segmentectomy 82%, and wedge resection 79% at 5 years. And again, the p-value was 0.8, and the hazard ratio was actually lower with segmentectomy 0.90 and lower with wedge resection 0.97, consistent with the primary results of the reported in the primary paper. We also looked at lung cancer specific survival. We had not looked at that before. And here, the only event that counts is death from lung cancer, everything else being censored. So 5-year survival was lung cancer specific survival was also similar across the 3 types of parenchymal resection, 87% almost after lobectomy, 89% after sublobar segmentectomy, and 89.7% after wedge resection. Again, the hazard ratio favoring the sublobar group, and the p-value was 0.9. Look, we then zeroed in on the wedge versus segment, and it's just a similar slide to the one I showed you before, except that here we're just simply looking at segments, which are shown in green, and wedge, which are shown in blue. And again, the solid lines are lung cancer-related death, a little bit more death after segmentectomy, lung cancer-related death after segmentectomy compared to the wedge resection, but not statistically significant. And the dashed lines are the competing causes of death, no difference between the 2 groups. What is interesting, though, is you can still see lung cancer-related death up to 4 years after randomization, which is speaks to the importance of constant surveillance of these patients. Disease recurrence was 30% in each group. Again, local regional recurrence was, as you would expect, a little lower after segmentectomy, 12.3%, compared to 14.4% after wedge resection. That difference, although numerically higher, was not statistically significant. And it certainly was not clinically meaningful because it had no impact on any of the survival outcomes that we showed you. But we also looked at the freedom from local regional recurrence between wedges and segment, given the slightly higher local recurrence rate. And as you can see, there is no difference between the two curves. Freedom from local regional recurrence at 5 years was 84.6% after segmentectomy and 82.7% after wedge resection. And the p-value was 0.98. So we next then looked at the margin. We had recommended that patients who, if a wedge resection, specifically if a wedge resection is done, that the surgeon try and get a 2 centimeter margin, and if failing getting a 2 centimeter margin, to get a frozen section or get a margin at least equivalent to the size of the tumor. I was really impressed that 84% of all the sublobar resection group had an assessment of the surgical margin intraoperatively by frozen section. That was higher after wedge resection, 87%, than it was after segmentectomy, 76%, probably because they felt a little bit more comfortable with the margin after anatomical segmentectomy. Overall, the positive margin in the sublobar resection group was seen in 3.5% of patients, 12 out of 335. It was slightly higher after wedge resection, 10 out of 204 patients versus 2 out of 131 patients. So 5% versus 1.5%. Of these 12, 2 were found on permanent section. The other 10 were remedied immediately at the index operation by additional parenchymal resection, whether it's a lobe or a segment or an additional wedge resection. We were predicting that maybe with after wedge resection, you would get better preservation of FEV1 and FVC. That was not the case. There was no difference. An absolute difference between the two was 2%, which is exactly the same absolute difference we reported in the primary paper between lobectomy and sublobar resection. So that did not seem to change by the extent of parenchymal resection. So now we come to the limitations of this analysis that we just presented. First of all, we have to remember that the patients were not randomized to the sublobar resection type. So this was left to the discretion of the surgeon. What contributed to that decision was not known to us. The other thing is the trial was not powered to test for non-inferiority of one type of sublobar resection versus the other. Next, there are things that I wish we could do, but we did not do. There was no central pathology review. We're trying to address that by creating a task force to collect some pathology slides from high accruing centers and try and look into that. We had an embedded imaging study. The images are all on disks somewhere in a secure location in the United States, but we cannot find the secure location. So when we find it, we will try and get somebody on that. So in conclusion, in this post hoc analysis of this trial, all survival endpoints were similar, regardless of the extent of the parenchymal resection. Patients treated by wedge or segment had similar rates of distant recurrence and local regional recurrence, and there was no difference in the magnitude of reduction in FEV1 and FVC between wedge resection and segmentectomy. What else are we going to do going forward? Well, we're going to look at various association between recurrence and various demographic, clinical, and operative characteristics. We're going to look at the relationship between the various types of adenocarcinoma and outcome, and things like lymphovascular invasion and STAS. And hopefully, if we ever get our act together and look at the imaging data, we may even be able to see whether or not there's an impact on the PET max SUV at baseline and outcome, and C2 morphology and outcome. And with that, I will stop and thank you for your attention.
Any comments from the audience? You have
the opportunity to comment on Dr. Altorki's talks when he's not here to defend himself. So my comment is, And I think it really shows the idea. I mean, everybody appreciates the power of doing this trial. Everybody wanted this randomized trial comparing lobar versus sublobar resections. And we saw it in the Japanese study, and now we saw it with Nasser study, and it got really global attention, and it's changing practice. But these trials, Nasser's trial took over 17 years to publish the results. I was there when, literally, when we got the trial approved, we were met with the CALGB, so I know. And I can tell you that surgical understanding of cancers in the past 17 years has dramatically changed. We weren't talking about subsolid cancers very much 17 years ago. It really was almost a new entity in terms of what we were doing with CT really and screening happening. And when both the Japanese trial started and when the CALGB or Nasser's trial started, both of them included subsolid cancers. The Japanese trial even included non-solid cancers in their randomization. And Nasser included only part solid cancers. I don't think, and the Japanese, somewhere in the middle of the trial, they then stopped recruiting patients with non-solid because they recognized that this was not worth randomizing. I am pretty sure that if Nasser had his chance to do this again, he would not have included subsolid cancers in, because I suspect that it doesn't matter very much whether you do sublobar resection or lobar resection. I think pretty much that could have at least been considered as a different type of procedure. And I don't think we really needed to know the difference. And I think that that affects the power of these studies. If you just wanted to look at the solid cancers, which is where the real concern is, I really think we would have wanted to see that separately, how they would have done if you randomized them to lobar versus sublobar. So I think that demonstrates what the difference in approach is. I think that the approach that we take in I-ELCAP, where we just continue to collect data going forward, we can look at that much more rapidly. You know, and so, for example, in I-ELCAP, we've collected more cases in a few years than in the 15 years they were accruing for these randomized trials. And it just tells you, you know, certainly the complementary nature of it. But I think there's a lot of, there was a lot of surgical knowledge accrued in the past 15 years that we would have done these trials differently. And that's the challenge with these long-term studies. And yeah, and if Nasser was here, I'm sure he would have said something to me. Okay, anyway, that's my comment.
Thank you. Thank you.
Any other question? A comment? I think Dr. Altorki underlined that in the future direction, the need of analyzing stats, maybe not only stats, but also embols, perineal spread, in order to attempt at understanding the relatively important rate of local recurrence. And remarkably, in this trial, there was no survival differences between arms, but the rate of local control, which is shown by the rate of local recurrence, is quite high. And maybe independently of the treatment arm, understanding the reason of this local rate could be interesting. I don't know if Dr. Altorki has a commentary on this topic.
Is Altorki online or not? No, okay.
No.
So if I may add a comment. Yeah, he was not afraid of being questioned.
But indisputably, there was a large difference in survival rates between the Japanese trial and the CALGB trial in terms especially of a local recurrence.
One more comment is that you know, most screening detected tumors are now adenocarcinomas and with a part solid component, which is I doubt you can generalize all these conclusions to, for example, squamous cancers. I think they are pretty much more aggressive, and I wouldn't feel that confident in offering a patient of mine wedge resection for a 2-centimeter squamous carcinoma. I wouldn't do that, despite the data. Yeah, they are not answering that. However, all this story reminds me a little bit about the history of breast cancer surgery. You know, they were offering Halsted mastectomy to everyone in the beginning. Now they are down to local resection stuff. But I think we still need to look into the data quite a bit before stating that this is the new standard of care.